This is Walter Kemp. This is Arteriosclerosis. I'm calling it Part 1, basically for the chapter from Robbins on blood vessels for arteriosclerosis and hypertension. I divide it into 6 lectures. The first one was the general review of vascular processes. This is the first one, arteriosclerosis. There'll be a second one. This is where we used to live in Missoula. This is looking out from our house, just a double rainbow there, which I always thought was kind of neat. And I always like to start out with the image instead of this slide. So this is Arteriosclerosis Part 1, the name of the lecture. Those are the 2 sites that the first one and the second one is Dr. Hughes have. These are questions. We haven't worked on them for a while, but we're going to probably get started here again. They're my Twitter connections. I haven't posted on Twitter in a little while, but I'm going to start doing that again, posting these lectures and everything like that. And once again, I'm a forensic pathologist, but I have a real strong interest in general pathology and systemic pathology, the organ pathology, and in teaching medical students. Since I never know who's going to view these lectures on YouTube, I have put in disclaimers. Please read the disclaimer. If you don't agree with it, then please do not watch the video. Third disclaimer, second slide. Once again, read it. If it does not apply to you and you have to say no to that, then don't watch the video. The thing about this is that if you want to see my teaching technique, stuff like that, just view my introductory presentation. Not a lot of people have viewed it, but if you want to know something about my teaching, it's right there. Here are the references I use. I really go off Robbins' Basic Pathology as my main source. I like the 10th edition before they took out all the citations. I start out each lecture with a question. What this does is it allows you to concentrate on things as you go through the lecture, and they say that this technique increases retention time, increases amount of retention. And I have 2 questions. So just stop it, look at it, try and answer it, and then go on, and at the end of it, we'll answer them. Here's the second one. So pause, try and answer it, and then we'll move on. So arteriosclerosis, there's actually 4 types of arteriosclerosis. There's atherosclerosis, there's hyaline and hyperplastic arteriolosclerosis, Monckeberg medial calcification, and fibromuscular intimal hyperplasia. So talk about atherosclerosis, and a lot of this lecture that follows is going to be on atherosclerosis, but also the arteriosclerosis since related to hypertension. So the bottom left, you see an opened aorta. The black arrow, you can see all those kind of little reddish, orange, yellow nodules. That's all atherosclerosis. The top right of it, this is hyaline arteriolosclerosis, so affecting the arterioles. And you can see the arrows, the black arrows, show these arterioles with this acellular pink eosinophilic thickening of the wall. That's hyaline, and it's associated with hypertension and diabetes. The bottom right is Monckeberg medial calcification. This is something that occurs mostly in older men, of which I now am. Occurs in the forearms usually, it says, and then it's in the media. Doesn't usually cause obstruction, doesn't usually cause any clinical problems. So the main thing we're talking about with arteriosclerosis is atherosclerosis, and then we'll talk about hypertension and obviously hyaline and hyperplastic arteriosclerosis we talked about there. So atherosclerosis is very important, very common. They say men usually have it before women until menopause when women catch up. In 2009, it was responsible for 1/3 of all deaths. It's coronary disease. It says about 2/3 of heart-related deaths. It's amazing when you say coronary artery disease, they usually always mean coronary artery atherosclerosis. There's obviously other coronary diseases, but it just means that atherosclerosis is so common that it's considered essentially the main or almost only coronary disease. And that's associated with the Western diet. So my point to ponder, and I like to throw these in, this is just my way of making people think, is coronary artery atherosclerosis truly responsible for so many deaths in the United States? And I'll pause while you think about it. So my answer will be probably not. A lot of deaths in the United States are investigated by coroners and medical examiners. And oftentimes when people are of a certain age with certain risk factors, individuals will be signed out without an autopsy because we just can't autopsy everybody. We don't have the manpower, the resource, or anything like that. And obviously there's other issues with that. Not all families want that or anything like that. But anyway, the main thing that people are given is coronary disease. So we usually will say arteriosclerotic cardiovascular disease. So that's listed as their cause of death, even though we don't necessarily know for certain. And so anyway, my argument would be it's probably not that high, but pretty close. So for atherosclerosis, there are certain risk factors. Robbins lists modifiable ones and the major ones: dyslipidemia, various terms you'll hear: dyslipidemia, hyperlipidemia, hypercholesterolemia. Tobacco use, smoking is very important, hypertension, and diabetes mellitus. And then non-modifiable, advanced age as you get older, and women when they hit menopause catch up with men. Male sex is always a major risk factor, and hereditary. And with this hereditary, it doesn't usually mean one gene. It means usually multiple genes. But hereditary is very important. I've seen people who had who are in their late 20s, 30s with really bad coronary disease, and family history is very important. It probably trumps all the rest of them, if you ask me, but very important. So very important to know your patient's risks in that. Other ones are inflammation, hyperhomocystinemia, the metabolic syndrome, lipoprotein A, which is homologous with plasminogen. I really like this one. It's kind of neat because what it means is that when the body's trying to activate plasminogen to plasmin so it can cleave fibrin in that, cleave thrombi in that, it actually tries to cleave lipoprotein A, which does not turn into plasmin. So it's kind of wasting its time, and so it kind of blocks the production of active plasmin for helping break down blood clots, and then therefore with more thrombosis and stuff like that, you're more likely to have complications. And then you just become hypercoagulable. So I'm going to semi-apologize for the next one, but not completely. So what I was doing is I was looking at I think it's important to understand the way cholesterol is obviously handled within the body. And this kind of shows it. So if you follow along, start at the top left with the intestine, that's where the food comes in. So when your cholesterol and that comes in the body, and the triglycerides, it comes in as chylomicrons. These transport the triacylglycerols, and they use apple B48. Then lipoprotein lipase is going to act upon that and release fatty acids. And you can see the fatty acids are then taken up in the peripheral tissue. However, this would be a case where if you have a lipoprotein lipase deficiency or ApoC2, which is an activator of lipoprotein lipase, then what do you get? If you block that step, you're going to build back up the one before it, and you're going to produce, bodies will have more chylomicrons, which are going to give you increased triglycerides. So the reason I put this together is just for that reason. Then if you kind of visualize it, I'm a very visual person. I usually like pictures, but here you can kind of visualize it. So you can see that if I don't have the lipoprotein lipase, the step back is the chylomicrons. So then what happens is the lipoprotein lipase breaks down to free fatty acids, which get taken to the peripheral tissue, or follow the blue arrow down. You get chylomicron remnants, which makes sense. You break down the chylomicrons, you get what remains. And you add ApoE to that, and then ApoE can bind to both chylomicron remnants or VLDL remnants, which then get taken up by the liver. So the liver is going to convert the LDL to IDL, and then output it as LDL cholesterol with ApoB100, which then gets taken up by the peripheral tissue, follow my line, or gets retaken up by the liver. And then that's where you see if you have LDL receptor problems and you don't bind it, that's where you get the increased LDL in the blood. So I kind of put this together like that so you look at things, and I would recommend sometimes if you try and make up things like this for yourself, it can help you learn the process. I hope it's helped some, and you see the way I'm looking at it, but you can kind of see where if you don't have the things like lipoprotein lipase, you have problems with the dis-beta lipoproteinemia. You can see what it affects and why you're going to get built up of certain things back from it and everything like that. So I hope that helps a little bit. Sometimes though it might be a little more complex. So the pathogenesis of atherosclerosis. So I remember when I learned atherosclerosis in medical school, it seemed like you tried to learn one step to the next step to the next step to the next step, and that's really honestly in general kind of the way it goes, but there's a lot of different ways and branches it can take, and there's a lot of different components to it. Not all the atheromas are the same. So what happens is the initiation, as we talked about with the first lecture, the endothelium becomes dysfunctional. So remember, the endothelium normally can cause vasodilation, vasoconstriction, promote or inhibit thrombosis, promote or inhibit the attachment of white blood cells. All those play a role in atherosclerosis. So if the white endothelium is not doing it correctly and it's dysfunctional, it's going to set up the ability for atherosclerosis to develop. Then as the atheroma develops, you get plaque, and then what happens is the plaque has complications. So you can get hemorrhage into it, you can get rupture of it and thrombosis. So the picture on the bottom left is an eccentric atheromatous plaque, but there's no real acute change. And then to the right of it, that's actually a plaque with rupture. And I'll show these later too and point out some of the features in it. But I figured I'd just throw some pictures in there. So if you think about it, it starts with endothelial damage, then there's a variety of things that go into the progression of the plaque that we'll talk about. And then it becomes clinically apparent when either the plaque gets too obstructing that causes too much stenosis, or you have some complication that causes something acutely. So once again, remember the normal functioning endothelium, it's anti or prothrombotic depending on what it needs to be. It causes vasoconstriction or vasodilation. It regulates immunity. It inhibits and promotes growth, and then it can oxidize LDL. So if it becomes dysfunctional and any one of these things in here isn't working the way it should be, any and all can contribute to the development of atherosclerosis. And what leads to that injury is, once again, trauma, toxins, inflammation, for example, smoke, metabolic things, diabetes, hypertension, the strain on the endothelium and stuff like that can cause it to become dysfunctional. And then with that dysfunction, what happens is you get, like I said, you get adhesion of white blood cells and monocytes. Those produce reactive oxygen species that oxidize LDL. And so LDL actually comes into and out of the intima, but when it's oxidized, it stays. And then what happens is the macrophages engulf those and become foamy cells. So to the right of it, the black arrow is showing a large cluster. You can see these large, clear-looking cells. Those are foamy macrophages. Those are macrophages with oxidized LDLs within them. And they engulf that LDL through the scavenger receptor. So what that's going to do is obviously lead to the accumulation of the LDLs. And on the slide with all the cholesterol movement and stuff like that, obviously that's an important point. And remember, people with the mutation of the LDL receptor with hereditary hypercholesterolemia get bad atherosclerosis at a young age. You have myocardial infarcts at a young age. T cells play a role. They can release gamma interferon that stimulates smooth muscle cells to enter the intima. Remember that the smooth muscle cells enter the intima, starts becoming secretory, and they produce the stuff that's going to cause kind of the fibrous cap, the covering of all this foamy material that you see. Okay. So once again, I just put a slide in the middle, kind of break things up. So this is the going to the sun road. That barrier of rocks there doesn't look like much, but it's actually pretty sturdy. I actually was on this road one time and saw a bus hit that, really wrecked the bus, but didn't damage the rock wall. So it's a pretty safe road. So T lymphocytes play a major role. They actually stimulate foam cells. Foam cells then release matrix metalloproteinases. So foam cells would be the macrophages that have the engulfed oxidized LDLs. They release matrix metalloproteinases that tend to break stuff down. So an atheroma has a fibrous cap, which is a covering of like collagen and stuff like that produced by the smooth muscle cells, overlying an atheromatous core. And so that cap helps kind of keep the core in place. So if you have matrix metalloproteinases in there that break down that material, it can lead to a thin fibrous cap, or what's called a vulnerable plaque, and that can rupture. It also inhibits smooth muscle, which normally produces collagen and elastin, and that builds a fibrous cap. And that fibrous cap is nice and thick and solid. That makes a stable plaque. So yes, they can be symptomatic, but a stable plaque is unlikely to change. Whereas a vulnerable plaque with a thin cap overlying a friable atheromatous core is likely to potentially rupture. And to the right of it, what I'm showing you the black arrow, those are just the lymphocytes. So here's the first question. Pause it, answer it, and then we'll answer it. A 64-year-old male develops an infarct of his heart due to a blockage in his coronary artery. Of the following, what was the most likely a risk factor for his condition? So when we talked about these, obviously the fact he's male and 64 are two main risk factors there. But of the ones listed, the only one I listed was the hyperhomocystinemia. So that is one of the more minor risk factors, but still a risk factor for atherosclerosis. A pathology pause, look at the question, answer it, and then we'll go on. A pathology resident examining a section of coronary artery from an autopsy. They identify an atherosclerotic plaque with a thick fibrous cap. of the following, which cell type played the greatest direct role in the development of the cap? And so the answer is smooth muscle cells. So remember, smooth muscle cells are going to secrete the collagen elastin that helps that cap develop. And then lymphocytes are going to be the ones that inhibit the smooth muscle cells, inhibit the production of the cap, and also will stimulate the foamy macrophages, the foam cells, to produce matrix metalloproteinases, which break down that fibrous cap. It actually makes it thinner into a vulnerable plaque that can be more prone to rupture. So once again, use reflection. Just go back, think of the lecture, and think about, okay, what are 5 things I learned from this lecture? I'm hoping you learned 5 things from this lecture, but this helps really cement the material. And like I said, make it stick. It said medical student went from the bottom of class, top of class, using this one technique. So, and I'm not going to give you the answers. You have to come up with them. And then once again, here's Glacier National Park. This is a little bit back from the one I showed you on the previous lecture. You can see very scenic, very beautiful. If you want to see animals, go to Yellowstone National Park. If you want to see scenery, go to Glacier National Park. Although if you're hiking, you can see grizzly bears and you can see mountain goats and stuff like that, and deer and everything. But very scenic, very beautiful. I hope this lecture has been useful. Thank you.